A 58-year-old man presented in the ER within 70 minutes of experiencing chest pains, nausea, and diaphoresis. Elevated cardiac enzymes and ST segment depression in anterior leads suggested acute coronary syndrome. Coronary angiography showed a lesion in the mid-LAD, and the decision was made to proceed with a percutaneous coronary intervention.
Mr. Jacobs, we found the blockage we thought we might see, and we're going to do the procedure we discussed earlier in the ER.
PCI was successfully completed in the mid-LAD of this ACS patient.
Mr. Jacobs, the procedure is done now, and the result looks good.
Medication prescribed post-procedure included an ACE inhibitor, beta blocker, statin, and dual antiplatelet therapy. Percutaneous coronary intervention, such as the stent placement in this ACS patient, causes damage to the arterial wall and disruption of the coronary plaque, resulting in the exposure of thrombotic substrates to circulating blood and coagulation factors. The exposed underlying tissue elements initiate platelet adhesion and activation, which, when uncontrolled, may subsequently lead to platelet aggregation and increase the likelihood of stent thrombosis. Dual antiplatelet therapy is recommended to help manage the prothrombotic environment in this ACS patient and reduce the risk of clinical consequences, such as myocardial infarction and death, which may result from stent thrombosis. In this same ACS patient, the progression of atherosclerotic disease and the resulting plaque formation is likely to continue throughout the vasculature. Plaques erode, fissures form, and spontaneous ruptures may occur as a result of the unpredictable thinning and destabilization of a plaque's fibrous cap. A platelet-rich thrombus is allowed to form as a result of the exposed prothrombotic components of the ruptured lesion. Prematurely discontinuing dual antiplatelet therapy in the ACS patient may result in future ischemic events, such as myocardial infarction and death, as a result of atherothrombosis. Percutaneous coronary intervention is a focal treatment of a systemic disease process, and patients require long-term medical management, including dual antiplatelet therapy and lifestyle changes to minimize the risk of atherothrombotic events. When dual antiplatelet therapy is continued in this ACS patient, platelets adhere, a monolayer is formed, and platelet activation is better managed if plaques spontaneously rupture. The risk of ischemic events resulting from plaque rupture and subsequent atherothrombosis can be reduced by continuing dual antiplatelet therapy. While advances have been made to slow the progression of atherosclerotic disease, we are continuing to learn how to manage the ongoing risks associated with atherothrombosis using long-term dual antiplatelet therapy. Unfortunately, we cannot predict when and which existing plaques may lead to an ischemic event. Continuing long-term dual antiplatelet therapy in the ACS patient after PCI may reduce the risk of myocardial infarction or death by preventing atherothrombosis caused by spontaneous plaque rupture. Current guidelines recommend dual antiplatelet therapy be given ideally up to 12 months in patients who have undergone PCI and who are not at a high risk of bleeding. Daiichi Sankyo Incorporated and Eli Lilly and Company are engaged in ongoing antithrombotic research and development. Our goal is to improve outcomes in patients with cardiovascular disease.